We are live, ma'am.
Hi, good evening everyone, and myself, Dr. Ramya, Clinical Head and Fertility Specialist at Oasis Fertility Center, Guntur. I welcome you all for the Facebook live session, and today's topic is pre-implantation genetic testing. I think this is something very interesting. So we'll move on into the topic, and if you have any queries, you can put it up in the chat box. That will be answered at the end of the session. So what is pre-implantation genetic testing? So even before ante implant avadanikana mundu, even the baby is getting implanted in the mother's womb, even before that stage, we are diagnosing if any genetical abnormality is there in the embryo. That is what is the meaning of this pre-implantation genetic testing. So baby mother womb lo కన్నా ముందే మనం పెరగడానికి ముందే మనం ఏమైనా జెనెటికల్ అబ్నార్మల్ ఉంటే ఆ ఎంబ్రియోలో టెస్ట్ చేసి ఆ ఎంబ్రియోని టెస్ట్ ద్వారా ఏదైనా అబ్నార్మాలిటీ ఉందా అని డిటెక్ట్ చేసేదే ప్రీ ఇంప్లాంటేషన్ జెనెటిక్ టెస్టింగ్ అనమాట. సో యూజువల్ గా మనం ఇంప్లాంటేషన్ అంటే న్యాచురల్ గా కన్సీవ్ అయిన తర్వాత అయితే మనం ఫ్యూ ఏదైనా ఇఫ్ వి థింక్ సమ్ ఫెమిలియల్ ప్రాబ్లమ్స్ ఆర్ ఫ్యామిలీ హిస్టరీలో జెనెటికల్ గా రన్ అవుతున్నాయి అన్నప్పుడు వీ డూ ఫ్యూ ఇన్వెస్టిగేషన్స్ విచ్ విల్ బి హెల్ప్ఫుల్. ఇన్ ద న్యాచురల్ కన్సెప్షన్ అయితే అవేంటి అట్ ద టైమ్ ఆఫ్ 12 weeks చేసుకునే కొన్ని investigations along with the NT and double markers, దాంతో పాటు amniocentesis, chorionic villus sampling, all these are all the few investigations. ఇదేంటంటే prenatal screening అంటాం. So after the embryo got implanted in the mother's womb and we do certain tests in order to diagnose, అలాంటివి prenatal screening. So అది natural conception అయితే ఆ మెథడ్స్ యూస్ చేసుకోవచ్చు. బట్ దిస్ ప్రీ ఇంప్లాంటేషన్ జెనెటిక్ టెస్టింగ్ అనేది ఐవీఎఫ్ అంటే ఇన్విట్రో ఫర్టిలైజేషన్ కి ఎవరైతే వెళ్తారో, లేదు ఇఫ్ దే నీడ్ దిస్ ప్రీ ఇంప్లాంటేషన్ జెనెటిక్ టెస్టింగ్ అన్న వాళ్ళకి ఐవీఎఫ్ చేయడం వల్ల మాత్రమే పాసిబిలిటీ ఉంటుంది అనమాట. సో విత్ దిస్ షార్ట్ ఇంట్రడక్షన్ ఐ విల్ మూవ్ ఇన్ టు అవర్ టాపిక్. So genetic testing, whenever it is done on the embryo before the time of the implantation, is the pre-implantation genetic testing. So this is our day 5 embryo or the blastocyst. See the outer trophectoderm layer and inner cell mass. So from these, ante ee bite unna ee cellular layer nunchi placenta develop avutundi, and this whichever you are seeing this pink color cells is the inner cell mass. Ante the fetus will develop from this part anamata. So usually manam biopsy cheseappudu we'll collect these few cells from these trophectoderm cells and ee cells ni manam analyze chestam. So this is the day 5 embryo anamata. Ante IVF ద్వారా మనం ఎగ్స్ స్టిమ్యులేట్ చేసి ఫీమేల్ పార్ట్నర్ లో డే 2 నుంచి స్టిమ్యులేట్ చేసుకుని ఎగ్స్ డెవలప్ అయిన తర్వాత వన్స్ ఇక్సీ చేసినప్పుడు దాని తర్వాత ఎంబ్రియో ఫామ్ అయిన తర్వాత ఈ ఎంబ్రియోస్ మీద మనం చేసే జెనెటిక్ టెస్ట్ అనమాట. సో అర్లియర్ ఏంటి అంటే ఈవెన్ ఫ్యూ దీనికన్నా ముందు మనం డే 5 ఎంబ్రియోస్ కాకుండా ఈవెన్ ఆన్ దిస్ డే 3 ఎంబ్రియోస్ మీద కూడా అంటే ఈ బ్లాస్టోమియర్స్ ని కూడా టెస్ట్ చేసేవాళ్ళు. లేదు ఈ పోలార్ బాడీ ఉంటుంది, సో ఈవెన్ ఆన్ దట్ దే యూస్ టు డూ. బట్ యాక్యురేట్ డయాగ్నోసిస్ అనేది చూసుకుంటే ఫర్ దిస్ బ్లాస్టోసిస్ట్ బయోప్సీ అంటే డే 5 బయోప్సీ చేసినప్పుడు ఎక్కువ యాక్యురేట్ గా మోస్ట్ లైక్లీ ఐ మీన్ లైక్ జెనెటికల్ అబ్నార్మాలిటీ కొంచెం ఎక్కువ శాతంగా డిటెక్ట్ చేసే అవకాశం ఎక్కువగా ఉంటుంది అన్నమాట. సో pre-implantation genetic testing, first thing I want to stress is only in IVF cases it can be done, and whoever needs they should undergo IVF, and then only it can be done. So after the stimulation, once embryo is formed, on the embryos ఏవైతే ఫామ్ అవుతాయో ఆ ఎంబ్రియోస్ మీద మనం ఈ టెస్ట్ అనేది బయోప్సీ అనేది ఆ సెల్స్ అనేది తీసుకుని టెస్ట్ కి పంపిస్తాం. సో దిస్ ఈస్ హౌ దిస్ సెల్స్ విల్ బి పిక్డ్ అప్ ఇన్ ది బయోప్సీ అండ్ సెంట్ ఫర్ ది బయోప్సీ. So what are all the genetic disorders we generally have? Maybe gene mutation problems or the chromosomal problems. So in the chromosome, if we see, there may be a structural abnormality or the numerical abnormality. And so as we all know, manaki 23 pairs of chromosomes ఉంటాయి. So even a number, numerical abnormality ante it may be more than, like if it is more than 46, maybe say 47 or 45. So the numerical abnormalities in the chromosome or any structural defects in the chromosome will lead to the genetic abnormality. The same way in the gene mutations also, there are single gene mutation. Ante only ఒక్క gene మాత్రమే ఎఫెక్ట్ అయ్యేది కొంతమందిలో ఉంటుందండి. Maybe multiple genes also will get affected in few patients. So all these are all the condition disorders what we generally have. So now coming to this pre-implantation genetic testing lo, first and foremost thing చూసుకుంటే recently they have divided it into pre-implantation genetic testing for aneuploidies. అంటే మనకి ఈ క్రోమోజోమల్ అబ్నార్మాలిటీస్ డిటెక్ట్ చేసే టెస్ట్ అన్నమాట. ఈ pre-implantation genetic testing for aneuploidies is a genetic test performed on embryos created through IVF to screen for chromosomal abnormalities. Second thing, previously this is called as pre-implantation genetic screening. So embryos with extra or missing chromosome. So as I already told, as we usually have the 46 chromosome, maybe an extra chromosome ante 47 kavachu ledu missing chromosome of 45. So such conditions can be diagnosed in this PGTA test. Okay, so embryos with extra or missing chromosomes referred to as aneuploid often fail to implant and lead to miscarriages. So abortions are chances atlantic embryos whenever they are abnormal embryos, such embryos if they are getting implanted, people may have recurrent miscarriages ala unde chances ekku untundi than placing an euploid embryo. అంటే నార్మల్ గా ఉన్న ఎంబ్రియో జెనెటికల్ గా అన్ని క్రోమోజోమ్స్ 46 క్రోమోజోమ్స్ పేర్స్ ఆర్ నార్మల్ అన్నప్పుడు సచ్ అన్ ఎంబ్రియో ఇంప్లాంట్ అయినప్పుడు దానికి ఉండే మిస్క్యారేజ్ రేట్ చాలా తక్కువగా ఉంటుంది. సో అబ్నార్మల్ ఎంబ్రియో వెన్ వీఆర్ ట్రాన్స్ఫరింగ్ అలాంటి ఎంబ్రియోకి మిస్క్యారేజెస్ రేట్స్ ఎక్కువ ఉంటాయి అన్నమాట. సో దట్ ఈస్ వాట్ విల్ బి డయాగ్నోస్డ్ ఇన్ ద PGTA, whether an embryo is abnormal అంటే క్రోమోజోమల్ గా నార్మల్ గా ఉందా లేదు అబ్నార్మల్ గా ఉందా అనేది మనం PGTA లో డయాగ్నోస్ చేయొచ్చు అన్నమాట. సో embryos found to be chromosomally normal are referred to as euploid and are the most likely to lead to a successful pregnancy. That's what, when a normal embryo అంటే జెనెటికల్ గా నార్మల్ గా ఉంది అండ్ దాని DNA కంటెంట్ కానీ దాని క్రోమోజోమ్స్ ఎవ్రీథింగ్ ఇస్ నార్మల్ అన్నప్పుడు such embryos when we are transferring into the mother's womb, that most likely have the chances of successful pregnancy of around 70 to 80%. So who should use the PGTA? PGTA general ga everki advise chestam. So whenever the patients of this advanced maternal age above 35 years or recurrent miscarriages unnai couples lo, అలాంటి వాళ్ళకి మేబీ 2 or more of the miscarriages or 2 or more of IVF failures. IVF failure ki one of the reason may be this genetically abnormal embryo also. So when repeated failures are there, then also we can advise to such patients for PGTA, or else any male factor infertility with a low quality sperm. So what I want to show you is, this is our general human karyotype having 23 pairs of chromosomes or 46 chromosomes. So if it is a female, we have this sex chromosome of XX and if it is a male, sex chromosome of XY we have. So in these chromosomes, if any abnormality is detected, like see, this is here when you see in the 23rd pair of chromosome, we can identify the defect as XXY. So this is an extra X chromosome. So that leads into a Klinefelter syndrome, which is a genetical abnormality. So these sort of abnormalities can be detected in the PGTA test. And in this, if you see, at this 23rd position, there is a missing X chromosome. Such abnormality can be detected. And at the 21 position of this autosome, there is an extra chromosome. So these are all things you can identify in the PGTA test when we generally look into this. Chromosomal abnormalities can be usually detected in the PGTA test. So PGTA test results, how we usually analyze are if number of this chromosomes per cell, if it is normal or abnormal, we will check it out. If it is normal, the likelihood of this pregnancy rate will be high. But if it is an aneuploid, and abnormal embryo, abnormal embryo, when we start transferring into the mother's womb, the most likely chances of pregnancy are very unlikely, and usually we don't recommend such aneuploid embryos to transfer. Only euploid embryos should be transferred to give a better successful pregnancy outcome. And the third one is mosaicism. And this, we have both, they'll have some normal cells and also some abnormal cells. Such a situation is the mosaicism. So here usually we don't prefer, but no other normal embryos are there for such patient. If the patient embryos were biopsied and in that all embryos turned to be a mosaic, no normal embryo, in only in such cases you can prefer the transfer of the mosaic embryo, but not on a usually if they have this euploid, chances to go like better to transfer the euploid embryo will be good. So in this mosaic embryo, the chances of successful pregnancy is low but possible in few cases. And the recommendations are actually it is not recommended, but provided may consider transfer if no other euploid embryos are there, then we can consider, but not regularly. A mosaic embryo should not be transferred. So this test, how accurate it is, where it can misdiagnose, and it happens very rarely. In few conditions where it becomes this mosaics or misdiagnose can happen is when you see this is the day 5 embryo, outer cells and the inner cell mass, the strophectoderm layer, when you see few cells are abnormal. This orange color if you see, or this yellow color if you see, these are abnormal cells, and few inner cells also had this abnormality. But when you take the biopsy from a normal area, it may show us to be a euploid or the normal embryo. So this abnormality is misdiagnosed. But here the real in the this condition is a mosaic condition where you have both this abnormal cells and also normal cells. When you take a biopsy from here and when it is turned to be mosaic, that is the accurate diagnosis for this embryo, it is a mosaic. But when you only pick the cells of this abnormal cells, then it will be turned to be an aneuploid or abnormal embryo. Again, it is a wrong diagnosis. So when you see the second picture, here only the inner cell mass. So as I already told, this from this outer layer of the cells, the placenta is developed, and from this inner cell mass, the fetus will be developing. So here in the second picture, when you see these abnormal cells are there in the inner cell mass. But when we are biopsying, generally we biopsy these outer cells. So again, this may turn into the misdiagnosis. Here, with these cells, it will be given. I mean, the diagnosis may be euploid, but in reality, this is a mosaic embryo. So this is how in few cases, whenever there is mosaicism, it may be misinterpreted. So this is a trophectoderm mosaicism, and here also the same thing. Whenever abnormal cells, if we miss, it may be turned to be a misdiagnosis. Most of the time, this misdiagnosis will happen in the mosaic embryos, not unusual. Whether if the cells are abnormal, aneuploid or euploid, may be most likely to be accurate. But whenever in these mosaic embryos, the diagnosis sometimes may be may not be that accurate. So, and next what we are going to this is, first thing I discussed right now is the PGTA. For the aneuploidies, the chromosomal abnormalities will be detected. And now we are going for the structural rearrangements. PGT for structural rearrangements. Here, as I already discussed, the chromosomes, one thing is the numerical abnormality, and the second one is the structural abnormality kuda undachu. So in these structural abnormalities, if we see, we have got reciprocal translocation, Robertsonian translocation, and inversions. So one, as I earlier I have shown you this chromosomes. So translocation is a part of the chromosome may be translocated to the reciprocal is the opposite side. So in that way, the translocations of the one part of the chromosome will be translocated to the other. So in that case, the structural rearrangements will happen. And again, in those cases, it may turn out to be, patient-wise, it may lead to some sort of miscarriages, recurrent miscarriages. So in that case, when we diagnose the patients, so patients can be tested for this by their karyotypic analysis. So when we see some karyotypic abnormality in the patients, such a structural abnormality can be analyzed in the embryos also. So moving into this second one is the structural PGT for the structural rearrangements. Sorry. This is a genetic test designed to detect inherited rearrangements and increase the chance of successful pregnancy. So who is it for? Usually, already if we know these patients are the carriers, okay, or else if they are having recurrent miscarriages in the couple. For such a couple, this can be advised. PGT SR is appropriate for people who have the chromosome rearrangement and thus are at risk of creating embryos with the incorrect chromosome number or structure. You may consider PGT-SR for chromosome rearrangements. If you had a child or a pregnancy with a chromosome rearrangements, or one of the partner is a carrier, in such cases, this can be advised. So how it works? Usually what happens is, in this chromosome rearrangements can be inherited or can happen spontaneously too. Means it need not be, it need not be in the couple. Many carriers of this balanced translocations or these rearrangements, patients may be healthy, but they don't know, they are unaware of their carrier status. So they will be unaware of the carrier status, but it will be carried on to the offspring, which may be causing their recurrent miscarriages. So that when we pick such patients who are having this recurrent miscarriages and are worked up for the karyotypic analysis, in few cases we can identify that karyotypic problem, and the same can be tested in the embryo. So carriers of this balanced rearrangements are at increased risk for producing embryos with the incorrect amount of chromosomal material, which typically do not lead a successful pregnancy. So PGT-SR can help identify embryos with the correct amount of chromosomal material that are most likely to lead to a successful pregnancy and healthy live birth. So finally, at most everyone needs a healthy pregnancy and a live birth for what we are struggling for. So that will be happen with the help of the PGT-SR in such couples. So the three type of this translocations we generally see are the reciprocal translocation, Robertsonian translocation, and the inversions. So this how can we test in the couple? That is what this is the general karyotyping what we do in the parents. So a couple comes and if they have the problem of this recurrent miscarriages, the karyotyping of the couple should be analyzed. So a balanced translocation is diagnosed through the test called karyotype, and in which these blood samples of both the parents are analyzed, looking for this translocation. And some research suggests that the balanced translocation in the mother is most likely to be associated with the recurrent miscarriages. Even in the fathers also can be a carriers as well. So as I already told, this is this Robertsonian translocation. Here, if you see the normal pairs of the acrocentric chromosome 15 and 21, the P arms are small and without genes. So what happens in the translocation when it happens is there is a loss of the P arm here and fusion of the two Q arms. So here what we see, there is this translocation completely with the one of this chromosome will be almost missing, and that will be elongated chromosome, which may be that complete missing of one of the chromosome. So there is a loss of the P arms and fusion of the two Q arms around a single centromere, and the functional DNA complement is normal, but high risk of trisomies and monosomies of this offspring will be identified here. This is how that Down syndrome we usually see in such translocations. And this reciprocal translocation. So this translocation between this chromosome 2p and 8q. So this is the chromosome 2 and this is the 8. So when you see this color change is there, that is how this translocations in the reciprocals will be happening. So in the reciprocal translocation occur when pieces of this genetic material break off from two different chromosomes and swap places. So from one chromosome, say from the 4 and the other is from the 8, there is a breakage of two pieces of the genetic material, and the fusion of the opposite the chromosomes will be happening in the reciprocal translocation. And people with this carry a balanced translocation can create embryos that have either the same balanced translocation, the unbalanced form of the translocation, or a completely normal set of chromosomes also can happen. If one parent is a carrier of this reciprocal translocation, 80% of these resulting embryos will contain an incorrect amount of this genetic material. So in these conditions, this PGT-SR will be helping out. And the Robertsonian translocations occur when two chromosomes join together to form one large chromosome, giving an overall chromosome count of 45 instead of 46. So this pairing occurs most commonly between the chromosome numbers of 1314 and 1421, as you earlier showed in the figure. So this is how it happens. So this may result in the Down syndrome, trisomy 13, or uniparental disomy. So this is the Robertsonian translocation. Now coming to the inversions. So inversion can happen only in the single chromosome itself. So here if you see the chromosome, the genetic material A, B, C is the a proper appropriate thing, but in the inversion it is getting reversed. But this is in the same chromosome, only the sequence is getting reversed. That is the pericentric inversion and paracentric inversion. Two types are there, but this happens in the single chromosome. Whereas this reciprocal translocation and Robertsonian translocation between the two chromosomes. So that is all regarding PGT-SR. So PGT-SR will be helpful in conditions such as whenever the couple is found to be a carrier, or when the couple are having any recurrent miscarriages, or already the couple's karyotype is known to be a significant carrier status of the couple. In such couples, PGT-SR will be helpful in knowing the embryo status, so that a normal embryo and unaffected embryos can be transferred into the uterus and can be helpful for a normal pregnancy. In sometimes when there is no normal embryo, then need to go for a donor oocyte in few cases. So now coming to the third one is the PGTM. So PGTM is the monogenic disorders or the single gene disorders. Monogenic is a single gene. So the single gene disorder, if you see right till now, all these two things we are talking about the chromosomal abnormality. So, but this is the gene disorder. A single gene abnormality can be detected by the PGTM. So this is the test. So here what happens is single gene disorders are caused by DNA changes in one particular gene and often have predictable inheritance pattern. So over 10,000 human disorders are caused by the change known as a mutation or a single gene, in a single gene, sorry. So individually single gene disorders are very rare, but as a whole population, it is affecting 1% of the population. Since only single gene is involved, these disorders can be easily tracked through families, and the risk of them occurring in later generations also can be predicted. That is how these disorders may be autosomal dominant, autosomal recessive, or X-linked dominant, or X-linked recessive. So that can be find out, and the transmissibility to the offspring will be known. And a few conditions only the male offsprings are affected. All such conditions also can be known, and we can help for a successful live birth. Single gene disorders can be divided into different categories, like as I already mentioned, maybe an autosomal dominant or an autosomal recessive, or X-linked dominant and X-linked recessive. So first thing is an autosomal dominant. So in this autosomal dominant, when one of the couple, so say this is the couple affected father and unaffected mother. When such a dominant autosomal dominant pair is getting married and they have the offsprings, almost 75% of the offsprings are tend to get affected, as only this will be the heterozygous transmission. And when this when these children get married, so when we see, even this is transmitted to the next generation, as this is an autosomal dominant, only a single means homozygous gene allele is enough for the transmission. That is why even this is transmitted to the next generation. And here also, when you see in the next generation, also it is getting affected. So in the autosomal dominant condition, we need to pick which like that defect first of all, that single gene disorder, where it is and what is it, how is it affecting. That will be known whether it is an autosomal dominant or autosomal recessive condition. It will be known, and accordingly the genetic counseling is done for the patient for the follow. So this is how this autosomal transmission occurs through generations. And autosomal recessive, in this autosomal recessive, to transfer to the next generation, it needs to be heterozygous. If the children should get affected, both the couple should have the gene. If only the mother is affected and father is unaffected, the children of such couple will only be the carriers. So they will not get affected. So only they become the carrier. But when these couples in the next generation, they can get affected because both the couple here are the carriers, and in such patients 25% of the affected children can happen when both the couple are the carriers. So when when both these genes, like heterozygosity is there, homozygous, it is there, then it becomes affected in the 25% affection rate will be there when it is an autosomal condition, and 50% of the carrier status, and 25% of the children may be unaffected. So coming to the X-linked recessive. So these autosomal recessive or autosomal dominant conditions, or the as I already showed you the chromosome mapping, chromosome chart. All these, other than we have got 23 pairs, and this 22 chromosomes termed to be autosomes, and the other one 23 is the sex chromosome. So whenever any gene getting affected in these 22 pairs of chromosomes, they are termed to be autosomal dominant. When the sex chromosome is getting affected, that will be the X-linked recessive or the X-linked dominant. The X-linked recessive, uh, in this condition, when you see a few conditions such as this hemophilia, and the other thing is this Duchenne's muscular dystrophy, in such condition, it is transmitted to the male offsprings, and most likely in this X-linked recessive condition, the female fetus, it will be a carrier, but only the male fetus will get affected. Because for the female to get affected, it should have the two XX. One X gene, whenever it is normal, the female will be the carrier. But the male offspring with this single X inheriting from the mother, male fetus will be affected in the X-linked recessive conditions, such as I told, this muscular dystrophies and the color blindness. Usually, male fetus will be affected. So when you come to see this chart, this couple, mother is unaffected and the father is affected here. When such a couple is getting married, if we think this is a couple of this color blindness, in such a patient, when they have children, the female children inheriting a gene from the father, only one X they will be inheriting from the father. So they are only the carriers. From the mother, the other X gene they will inherit, and so that they are only the carriers. But when these carrier female children, when they have the baby, when they have a male baby, the X gene will be inherited from the mother and Y from the father. Uh, and in this, male children will be affected in the X-linked recessive condition. That is how in these monogenic disorders, this PGTM, these will be helpful when to identify whether this is a recessive condition or X-linked, so that the transmissibility can be understood in such conditions, and we can help the couple for having a normal baby. And this is the X-linked dominant chart. So most likely when we see this here, both the males and the females will be affected, because only the single, as it is a dominant, both males and the females will be children will be affected in the X-linked dominant disease. But in X-linked recessive, female children most likely will be carriers and males will be affected. So if we see recent advances in this PGTA, till now we are actually doing this biopsy of this trophectoderm cells. What recent advances is the non-invasive PGT. So here what they are doing is the cells are cultured in a media. Sorry, the embryos are cultured in a media, right? So the media, wherever the embryos are placed in the culture media, the embryos will shed few cells or their DNA. So that spent culture media is picked up for the cell-free DNA of the embryo without biopsying the embryo. As in the earlier slide or the first slide, what I have showed, what we are generally doing is biopsy of the embryo. But recently, only from the cell culture media or the fluid, we are trying to identify this cell-free DNA of that particular embryo, and they are analyzing that DNA material for the genetic analysis. And one more thing is blastocele fluid, the fluid from the blastocyst embryo. So these are all the newer advances. So take home message. So the three main genetic testing what we do, and all this genetic testing only can be done in the patients whoever are undergoing IVF, but not in the naturally conceived patients. In natural conception, there are the prenatal screening. They are different, and only the embryos which like only in the IVF we can do this pre-implantation genetic testing. So first thing is pre-implantation genetic testing for aneuploidy, where only the number of where this test determines whether the correct number of chromosomes are present in the embryo. And second thing is the PGT-EM or the monogenic disorders. This test screens for the single gene disorder such as cystic fibrosis or BRCA1 mutation and Huntington's disease. All these sort of diseases can be identified in the PGTM. And PGT-SR screens for the chromosome rearrangements like chromosomal inversions and translocations. So these are all the three main tests generally we are doing on the embryos based on the history of the patient or the couple. So thank you so much. If you have any questions, please put it up. Sorry. So any questions? Okay. Okay. Hello, ma'am. Myself, Rupa. Our first question. Want to know that after egg retrieval, if embryo form, then my question is that if they will do PGTA test for all embryos, how much we get after fertilization in IVF? So I think what all our embryos were formed, on all the embryos does we do the biopsy you meant, I guess. So that depends on the couple. If based on the number of the embryos are formed, out of that they can first that is to the up to their wish. If we need to at least usually 40% of the embryos will be formed from the total oocytes we collected, and from that is the patient's wish. If total number of embryos they want to send, even all the embryos can be sent for the biopsy, or if they want to send the best out of the embryos cultured, even that it can be done. So our second question is, what are the risks of pre-implantation genetic testing? So basically risks, so it is invasive procedure what we are doing on the embryo. That itself one of the risks and the cost factor. And mainly whenever we have this mosaic embryos, there may be a misdiagnosis, or the accurate interpretation may not be possible in few cases. That may happen. So when is pre-implantation genetic testing done? That is what, whenever a patient is elderly aged patient with above 35 years, or else if they have the family history, or the couple with a known carrier history, or a child born with abnormality. In such cases, they can go for the pre-implantation genetic testing. So does PGT increase success of IVF? Yeah, definitely. Definitely, it will increase the success of IVF to at most 70 to 80% of the chances. When you place a normal euploid embryo, the chances of success of this successful pregnancy turns up to 70 to 80%. Okay, I think we are done. And thank you so much. If any queries, you can contact our helpline. We are here to help you. Thank you so much.